to do L5 exiting nerve root, DRG pulsed RF. First, we will do true AP and end plates parallel. Then we will do ipsilateral oblique. This is the pedicle of L5, and here we will go through subpedicular approach to target DRG of L5, exiting nerve root.
Local anesthetic.
RF cannula is inserted in tunnel vision. Take lateral view to confirm the depth. Insert the cannula till neural foramina entrance. After appropriate needle position, do sensory stimulation and ask the patient for paresthesia along the nerve distribution. Insert the needle furthermore till the patient experiences paresthesia.
Basically, I am almost touching the bone. Okay. Normally, it comes in the posterior surface, but the anatomical location always varies. So the best thing is you have to elicit the paresthesia. Till you are getting the paresthesia, understand that you are not sufficiently close to your DRG. चलो आगे चलो. If you are giving, अभी तो कुछ नहीं हो रहा है ना?
अभी सर नहीं हो रहा है.
Don't move. Huh? What is important when you are giving the steroid, then we are going posterior part because we are not stimulating, and we are sure that we are not going to damage anything because the volume will be covering the whole of the DRG and the nerve. But when you are doing the the PRF, then unless you are reaching very close to the nerve, the effect will not be there. So, and how to know that whether you are very close to the nerve? By stimulation.
After DRG pulsed RF is done, give contrast and look for dye distribution in AP view and give steroid. After giving steroid, we can see clearance of contrast.